started, I want to welcome our first UMEM alumni for our Critical Care Symposium, Dr. Samantha Wood. Sam, if you could come up front. Sam completed our EM/IM Critical Care program in 2012. Afterwards, she then headed north to Maine. So she is currently an associate professor in the Department of Emergency Medicine, practices clinically at Maine Medical Center. And we're going to get started where it actually all begins, in the Resus room. So please welcome back Samantha Wood to get us started for the symposium.
All right. Mike, thank you so much for that introduction. It is so special to be back in Baltimore after so many years and to see old friends and to be back in this room speaking to you all this morning. I'm going to talk about metacognition today. Metacognition is thinking about thinking. And one of the reasons I have this interest in this topic is that I've been really lucky over the last decade or so to have a role teaching first and second year medical students how doctors think. And it's really fun. You can imagine how interesting and challenging it is to take someone who's never had a patient encounter before and try to help them learn, how do you gather that information? How do you synthesize it? How do you make a differential? How do you think about the case? I don't have any disclosures except that I have a lot of nice pictures of Maine. This is Mount Katahdin. My agenda this morning, we'll do a quick review of dual process theory, which might ring a bell to a lot of people. It's been kind of in the pop media, the two ways in which we think. Then I'm going to tell you that type 1 has a little bit of a bad reputation that I don't think it deserves, type 1 thinking. But we will also go over why we still need type 2. So those terms probably, as I said, ring a bell for some people. But just to recap, we pretty generally have an accepted idea that we have two ways of thinking, system 1 or type 1 and system 2 or type 2. This is pretty validated, generally accepted paradigm for how people, not just doctors, but anybody, approaches thinking in their lives, in their day-to-day lives. Type 1 thinking is where you spend most of your time. Type 1 is fast. It is effortless. It comes to you automatically. It is how you recognize what's going on in familiar situations, and it's not really distractible. You can have a lot of other stuff going on, and you can do type 1 thinking and still be pretty successful. Type 2 thinking, by contrast, is hard, and it is effortful, and you need to have quiet around you to do type 2 thinking. When I am in the ED working a shift and I have a patient that's a little complicated and I kind of recognize that I need to do some deep type 2 thinking about this patient, I can't sit in my normal chair where the attending physician sits because 17 people will come to give you an EKG or ask you a question. It just doesn't work. I have to go hide for 3 minutes or 5 minutes to be able to devote that effort to my type 2 thinking about the patient. And as this kind of paradigm of type 1 and type 2 thinking begins to be applied in the field of medicine and is applied to how do we arrive at a diagnosis, how do we think about a diagnosis, it traditionally kind of followed into this very linear flow. You would see a patient, the idea is that you see a patient, you gather some data, and you have in your mind kind of the effortless, spontaneous bubbling up of a list of possibilities or a list of diagnoses or a concept of what's going on with that patient. But type 1 was also kind of criticized a little bit because it was thought to be the place where bias would occur. This is where you're at risk of making a mistake, of having a bias intrude. And type 1, although quick and easy, it's maybe thought kind of unreliable and not that accurate necessarily, and the place where you're going to make a mistake. So you have your type 1 thinking and ideas bubble up, and then you must progress to the next step and double check it with type 2. You got to apply your diligent, deep thought process to that initial spontaneous, rising up of an idea, and that by doing so, you will arrive at the correct answer. So this schema really I feel like it kind of weights type 2 as the way that a real diagnostician would think. and type kind of dismisses type 1 as the culprit for all bad thinking or all incorrect thinking in the diagnostic process. And coming at it from kind of reminiscing about doing dual training in emergency and internal medicine, that very type 2 heavy thought process reminds me of rounding for hours on medicine service. These guys look like they've been rounding for hours, right? Somebody over there has just given a 25 item differential diagnosis for hyponatremia. And that guy is saying, well, yeah, we auscultated and we percussed, but have we checked agophony? And I think that lady in the back is probably wondering, well, could it be porphyria? And if this crew of physicians heard about the dual process theory, I think they'd probably be pretty skeptical of type 1 as well, right? It's fast, it's quick, it's making rapid decisions on limited information. It sounds really bold, sounds kind of risky, sounds a little crazy. I mean, it honestly kind of sounds like the kind of thing an ER doctor would do. But I'd like to try to convince you over the next few minutes that type 1 thinking does not deserve its reputation as the root of all error, and that type 2 is not actually the be-all and end-all of how a doctor should think. I doubt anybody needed to do a lot of type 2 thinking to get a visceral reaction to this EKG, right? You see this, and you know what's going on. Imagine you're in the ED, you hear a complaint from a patient, they're talking about their chest pain, sounds a little atypical, you lift their shirt, you see this rash. You're not filtering through a 37 item differential for a rash, and you're actually not even saying to yourself, vesicular lesions on an erythematous base and a dermatomal distribution, right? No, you look at that and you're like, that's zoster. How do you know? You know because you know. You know because you've seen it. You know because your type 1 thinking system guides you immediately to the correct diagnosis. And it turns out in the literature that is available, which is not a ton, granted, you can imagine this is kind of a tough thing to study, that type 1 thinking is probably pretty good, maybe just as good as type 2 thinking, maybe just as accurate, and certainly a heck of a lot faster. In studies that take physicians at varying levels of training and give them clinical vignettes, and the people in the study are told either go as quickly as you can but be accurate to make the diagnosis in these cases, or they're told we don't want you to make any mistakes, go as slow as you need to, be very deliberate. The number of correct answers is actually pretty similar in the end. If you take physicians in various levels of training, you give them a bunch of vignettes and you say, go quickly, go fast, get through these cases quickly, but be accurate. And then you give people a chance to go back and revisit their answers and reassess them and you tell them, take a lot of time, we really want you to think deeply. They actually don't do that much better the second time around. It's kind of like if you know it, you know it, and sometimes adding that deep, effortful thinking doesn't add much to the correct diagnosis. There's even some places where it seems like spending too much time thinking deeply might not be of benefit and actually lead you more towards an incorrect diagnosis. People who participate in studies where an X-ray, either normal or abnormal, is flashed up in front of them for either a very quick, brief interval or for a longer time, people, especially residents in that phase of their training, the longer they have to look at a normal X-ray, the more likely they will find a false positive, right? So like your gut instinct, your type 1 response is, oh, that's normal, and then you ponder it for a while and you're like, oh, I actually think I see this thing that's abnormal when the image is actually normal. So type 1, I don't think it deserves its kind of like risky, maverick, dangerous reputation. It turns out that it's really pretty good, and it's what we have to rely on day to day in the emergency department. There's two catches, though, to this. And the first is that your type 1 thinking and your skill with type 1 thinking is only as good as you train it to be. When an experienced clinician walks into a room and recognizes instantly what's going on, that's not them being lazy, and it's not them taking a shortcut. That's a hallmark of their expertise. Type 1 thinking is not intuition, even though we commonly refer to it as intuitive, but it's not intuition. It's not magic. It's not spidey sense. It's not ESP. It is recognition of circumstances that you have seen before. So I showed you earlier a couple of slides of visual diagnoses that I thought probably everybody would recognize. This is a picture of a rash that the first time I saw it, I did not at all recognize. I was kind of freaked out. Pediatric patient, fever, looks okay, but has this really kind of concerning, weird, really ugly looking rash with all these violaceous spots within it. And the first time I saw this rash in a pediatric patient, I was deep in type 2. I was like looking stuff up and calling consultants and going back in the room 5 times to get more history because I did not have the ability to recognize this right off the bat. And I learned that day that this is urticaria multiforme, benign rash, looks really scary, but pretty benign, usually viral or maybe a medication reaction. And then the next time I saw it, I still had to type 2 it a little bit because I wasn't super confident in my ability to make a quick diagnosis. And then since then, I've seen it a few more times and am able, because my brain has been trained on that recognition pattern, to say, oh, that's urticaria multiforme. I see it, I know what it is. My type 1 thinking has become good at recognizing this rash. Medicine is changing all the time, and so stuff keeps coming up that you have to like train your brain to recognize or train yourself to see patterns. 5 or 10 years ago, if I was taking care of a diabetic patient and I got this lab result pattern back with a really elevated anion gap but a normal glucose, I would have been scratching my head and like looking up mnemonics and trying to figure out what's going on. And now, after a few years of experience with this kind of presentation, I know to immediately shift my eyes over to their medication list and look to see if they're on an SGLT2 inhibitor, because this patient likely has euglycemic DKA. It's become automatic. I hope that we do not find ourselves becoming type 1 experts in the rapid diagnosis of measles. I had my first rule out measles case in RED within the past month. Unfortunately, it wasn't measles. But what struck me about that case is that I learned about measles in medical school. I have received constant reminders of how to evaluate and diagnose measles over the last several months as my institution and our institutions as a whole try to prepare us for, possible influx of patients with measles. And yet, even with all that like book learning and paper learning, I still felt kind of flummoxed when I saw a patient with a rash and was asked, could this be measles? And again, I was deep in type 2, like cough, coryza, conjunctivitis, Koplik spots, how does the rash progress? So again, I hope we don't become people who have to, be able to have a type 1 recognition of a child with measles. But that really struck me how all the paper and book learning, which is very important, it just didn't really translate to that real life setting. I couldn't get that automatic knowledge from the books and the papers that I had read. And that brings me to my next kind of call to action for you guys for how to robustify your type 1 thinking. So I've said type 1 thinking is only as good as you train it to be. And you're certainly training your type 1 thinking every day by showing up to work, learning from your mentors, seeing patients. That's fantastic. That is exceptional learning to train your type 1 brain. But it's really, not that it's not good enough, but it could be better. And the reason is that I imagine most people in this room, have a process where you follow up on your cases, right? You save them, you're actually required to as residents. You have cases where you keep the e-number or you put a note to yourself or whatever. And probably, I'm going to guess, it's like the interesting cases or the weird cases or the ones where you were kind of uncertain that you tend to follow up on the most. To make that process even better, you've got to realize that if you see a patient and if you see a patient and things went great and you hear about it, awesome. You file that away in your brain as like a case where I got it right. If you see a patient and you had a cognitive error, you made a wrong diagnosis, whatever it may be, and you hear about it, then fantastic. You file that away in something I need to think about or work on. But if you never hear what happened with that patient, your brain will automatically put it in the bucket of I got it right. So I'm going to give you an example about a mistake I made recently, which, I'm going to come visit back to where I trained and tell you guys about one of my latest mistakes, but we all make them, so here we go. Because it was such a good example of this exact phenomenon. So a few weeks ago, I was working a triage shift, ripe for bias and error, right? And the role that I was working, our job is to catch every patient that comes in the front door, get orders started, but also to try to pick off the patients that can be easily dispositioned and get them disposed. So sent in to be admitted to whoever, to assign yourself to that patient and take care of them. Had a lady come in who was sent in by her ophthalmologist, and she had had partial vision loss in her right eye about 36 hours prior. Called her eye doctor, went to see her eye doctor. He diagnosed a partial branch retinal artery occlusion and appropriately sent her to the ED to get a neurologic workup. So I meet her in the triage booth. The nurse is doing triage. I kind of quickly get some more history. I do a quick neuro exam, nothing else concerning. I pop in our subacute stroke order set, boop, boop, boop. I consult neurology, and I put in a bed request to place her in to admit her to the hospital. And maybe 3 minutes later, our ED tech brings me her EKG. And as she handed me the EKG, I thought, I wonder if this patient's an AFib. Look at this EKG and, of course, do the normal, scan of an EKG that we do. But, I wonder if she's an AFib. Looked at the EKG. Nope. Sinus Brady. That T wave looks a little funny. All right, sign and send it off. And I honestly kind of debated whether or not to add this patient to my pretty long list of follow-up patients. So I was like, is it really going to be that interesting? This seems pretty routine. But I did. Maybe I'll see what her source was. And then I looked back a week later, and she had gotten a pacemaker because the EKG was not sinus bradycardia. And in my defense, I was not the only one that missed it. It was also missed by the admitting team and the cardiologist who read it the first time. Sneaky EKG. But she had complained of palpitations the next day, and so that led her team to really scrutinize her EKG and to get another EKG. And it showed that she was actually in 2-to-1 AV block. And when I said, that T wave looks a little funny to myself, it was because the extra P wave was buried in the T wave. If I had not followed up on that lady, nobody was going to call me and say, hey, Sam, you got this EKG wrong. I never would have known. I would have absolutely filed that away as in the file folder of cases that I got right, cases that I nailed. I got her dispoed quickly, I did everything right. And I felt so lucky that I had had the opportunity to catch this mistake and to learn from it. And I'm looking forward to the next time I see a funny looking T wave, because I think I'll do a lot better, being able to attend to that and recognize it. As I said, I know everybody probably does a follow-up strategy, but giving it a little extra attention, thinking a little bit more about how you can really improve your type 1 thinking, that's one suggestion that I have to make for you today. We're talking about metacognition in the recess room, but how well your type 1 thinking functions has a lot to do with what you do outside the recess room before you even get there. And the experts in the field also have a lot of support and publications to support this personal QA process. Another specific suggestion that can help is picking a particular illness or a particular topic and following up on every patient with that thing for a period of time. For the next 2 months, I'm going to follow up every chest pain patient I see. For the next 2 months, I'm going to follow up every pediatric fever I see. Just giving your brain that practice. What did I get right? What did I get wrong? And when you have that case that you thought was straightforward or easy, and you find out that there was a twist or a turn, that's the real gold for training your type 1 thinking. Systems also, very helpful in this process. Um, I work with our case review process, which I think is like type 1 training on steroids, because you get to see everybody else's cases where things didn't go great. And also trying to have that feedback come to you. So if you can have, your consultants sending their notes back to you, that's another helpful way. I wish we had better process for that. The one group that does it really well is our orthopedic doctors, which is pretty awesome because there is no better feeling than reducing a fracture in the ED and splinting it, and then seeing afterwards that the orthopedist thought your reduction was adequate. It's a little hard to get like a lot of praise from them, but yes, so I feel really good. Adequate splinting and reduction. But you guys know, and I know that this is not the whole story, right? Because I bet everybody in this room can think of a case where all the knowledge and all the skill and all the experience was in the room and we still didn't get it right. And when you looked back, you said to yourself, why didn't I think of that? So we're going to pivot over to type 2 and a few tips that are going to apply in the critical care room. How can you make that switch into type 2 thinking, and how can you make it a productive moment when you're engaged in this like really high stress crisis situation? What I'd like you to think about doing is taking a diagnostic pause, which, as I mentioned before, it's great if you can step away and think deeply in a quiet corner, but nobody's going to really like it if you run out of the recess bay to do that. So how do you incorporate a diagnostic pause into all that activity and stress and chaos that's happening in that room? My suggestion is to think of events that might happen in the critical care bay that should trigger a diagnostic pause. Give you that hint to say, ooh, I should shift my perspective, I should ask a question, I should take a little pause. One great place to do this is when something unexpected happens. You give a treatment and it doesn't do what you thought it would. Or you find a finding on the patient that you weren't expecting. Say, oh, this is a time to take a diagnostic pause. Another great opportunity is when someone else speaks up, especially if someone speaks up and says something that annoys you. Because that is that person giving you a gift and giving you the opportunity to pivot away from your automatic pathway and attend to a different possibility. What are you going to do when you get there to your diagnostic pause? Well, there are a million checklists that are published that I will not belabor you with. I think you should ask yourself one question. All the checklists kind of boil down to this question. The question is, what if I'm wrong? What if I'm wrong about the diagnosis? What if I'm wrong about the treatment? This is called prospective hindsight. It literally takes a second to imagine, what if I'm wrong about this? If you want to do some extra credit, you could also consider in that moment whether there's any bias at play. There are, as far as the last paper statistic that I read on this, there are something like 280 different biases that have been described in the literature. It's like everybody needs to have their own bias. I don't think you need to know about 280. I think, this is purely my opinion, that these two are the most useful in that high stress, intense resus room setting. Anchoring bias, which of course is anchoring on your preferred diagnosis, but more importantly, when you have falling prey to anchoring bias, you are also disregarding discrepant information. That's part of it. So ask yourself, am I anchoring? Am I anchoring on COPD exacerbation when this could be PE? The second important bias is affective bias. Most of the time, that's because you having bias because you don't like the patient. Sometimes it's liking them or having a very favorable feeling towards them that might change how you behave. But I think oftentimes affective bias arises more from somebody who's being very loud or annoying or demanding or violent or even dangerous. If you use your diagnostic pause to think about bias, I really think that just considering and naming these biases really diffuses them quite a bit. Am I anchoring? Am I having affective bias? And almost like just by considering it, you can overcome it. Another trick which I think is like this amazing combination of where type 1 experience and type 2 thinking come together, is called cognitive forcing. These are your when I, then I rules in medicine. So I'm going to bet that this room can complete this sentence for me. When I consider kidney stone in an elderly patient, I also think about. Dr. Martinez is smiling. Who knows? Yeah, great, right? Ruptured AAA. I was taught that, and I was probably taught that by Dr. Martinez. I was taught that in residency. You guys have been taught that. So that's one of your cognitive forcing methods. These are your rules that you have learned through the teaching of your mentors and through your experience that give you an automatic type 1 prompt to pivot over to type 2 thinking. A couple other examples, when I diagnose DKA, I always ask, how come? Why are they in DKA, right? When I diagnose cellulitis, I always think about septic joint, abscess, and necrotizing soft tissue infection. I also call these the ask me how I know rules, because so many of them arise from situations that you've been in before. And if you are deliberate about saying, well, next time I see X, I'm going to do Y, you can create your own cognitive forcing rule. And next time you're in that situation, you're going to have that recognition. For me, one of my favorite cognitive forcing rules is whenever I see a patient with a malignancy and I think they might have a PE, I also consider pericardial effusion and tamponade. Ask me how I know, right? So you see it once, you make a rule, and then next time you're a better physician for that patient because of your experience. The last thing I want to say before I finish up is just a little discussion about why this topic is so important to me. So of course it's important because we want to do the best for our patients. We want to make an accurate diagnosis. But to me, this is also important because we do a hard job. And there are many things like shift work and night shifts that get harder about this job as you progress along in it. And as I've kind of transitioned and been in that mid-career phase, you begin to hear a lot of talk about buying down your clinical time and exit strategies and escape plans and backup plans. But I think that these moments in the ED where the power of experience comes shining through. When I walk into a room with a patient who might have a confusing story, maybe there's a learner in there who's a little bit flummoxed, and that feeling of, I know what's going on here because I've seen it before, that is just one of my most joyful moments on a day-to-day shift. And to me, those moments where I can recognize how powerful the experiences and the benefits of spending many years in this career, to me, that is burnout prevention, and that is career longevity. There's a reason they call it the practice of medicine, and I hope that I have given you a little bit of clues and keys to help you with your practice. Thanks so much.
All right, thanks so much, Sam. Phenomenal way to get things started here at in our symposium. Let me first go to Dr. Chu. Anything in the chat, and let me bring you the mic.
Thanks, Dr. Winters. It looks like George in the chat would like to know what you think could be done at the residency level to develop type 1 and type 2 thinking.
So I think a lot of what you're doing is already developing your type 1 and type 2 thinking. I think the specific actions that you can take are, like I mentioned, really expanding those follow-up strategies to make sure you're catching the cases that you might not think are going to be interesting. I would love, I don't know how to cultivate this kind of culture at my hospital, but I think there remains a little bit of a hesitancy to sometimes to give people feedback, right? Like nobody wants to go up to their partner and be like, hey, remember that case you saw yesterday? And we do it because it's important, but we should I think that that could be can be increased as well. We at my hospital are actually just starting this week to get in our in basket every 72-hour bounce back that you have. So I think it remains to be seen what the signal to noise ratio will be on that and if that will be helpful. Honestly, I think the biggest component is just acknowledging these two ways of thinking, kind of naming it, naming biases, and paying some attention to it. I love it when a resident comes up to me and says, well, I might be having some availability bias, but here's what I think is going on. So those are some suggestions.
All right. Thanks so much, Sam.